Welcome to Evidence Mastery with Dr. Masoud Tusi. I am going to help you understand what Parkinson's disease is and how it is managed. Please note that this video is for education only and will not replace your doctor's advice.
Today, we're going to take a deep dive into Parkinson's disease. It's a condition that affects millions of people, and there's a lot to unpack. We're going to look at the science behind it, the signs to watch for, and how we approach its management today.
So here's our roadmap. We'll start with the big picture. What is Parkinson's? Then we'll zoom in to see what's happening inside the brain. After that, we'll cover how to recognize the symptoms, how a diagnosis is actually made, and finally, we'll talk about the different approaches to treatment.
Okay, let's jump right into section 1 and tackle that first, most fundamental question. What exactly is Parkinson's disease?
Well, at its core, Parkinson's is a progressive degenerative disorder. Now, those are important words. Progressive tells us that its effects tend to get worse over time, and degenerative points us to the root cause, which is the slow breakdown and loss of neurons, those crucial cells that make our nervous system work.
So just how common is it? Well, the evidence gives us a pretty clear idea. A study from 2022 showed that about 0.6% of North Americans over the age of 45 are living with Parkinson's. That might not sound like a huge number, but it goes up quite a bit with age, making it a really significant challenge for our healthcare systems.
You know, it's also really important to make a distinction here. Most cases are what we call idiopathic, which is just a medical term for we don't know the exact cause. This is what people usually mean when they say Parkinson's disease. But we have to separate that from other forms of Parkinsonism where similar symptoms might be caused by something specific, like a medication or as part of a totally different neurological condition. All right, so we've defined it. Now let's go a layer deeper. To really get a handle on Parkinson's, we have to look at what's happening inside the brain on a microscopic level. The whole story really starts with a protein called synuclein. Now, this protein is supposed to be there. It has a job to do in our neurons. But in Parkinson's, something goes haywire. It starts to misfold. It literally changes its shape. And then these misfolded proteins begin to clump together, forming these sticky, toxic clusters we call Lewy bodies. And this is the smoking gun. When pathologists examine the brain, the one defining feature, the absolute hallmark of Parkinson's, is finding these Lewy bodies built up in a very specific brain circuit called the nigrostriatal system. That pathway is a huge player in how we control movement. So these Lewy bodies aren't just sitting there harmlessly. No way. They are toxic, and they directly cause the death of a very particular type of neuron. The main site of this damage is a tiny part of the midbrain called the substantia nigra. It actually means black substance because these specific cells have a dark pigment. And here's where it all comes together. Those cells that are dying in the substantia nigra, they happen to be the brain's main factory for a neurotransmitter called dopamine. So as these neurons die off, the brain's supply of dopamine plummets. It's this dopamine shortage that is the direct cause of all the classic movement or motor symptoms of Parkinson's. Okay, so we've connected the dots from a misfolded protein to a dopamine shortage. Now, let's bring this out of the brain and into the real world. What does this actually look like? Let's talk symptoms. The evidence consistently points to 4 core motor symptoms. First, there's a tremor, but specifically when the limb is at rest. Second is rigidity, a kind of deep, persistent stiffness. Third, we have bradykinesia, which means slowness of movement. And finally, postural and gait instability, which leads to problems with balance and walking, usually later on. For a lot of people, the very first sign is actually quite subtle. It often starts as this slow, rhythmic tremor in just one hand, and only when that hand is completely relaxed. It's often called a pill-rolling tremor because the motion looks a bit like someone rolling a tiny pill between their thumb and index finger. But here's something that's absolutely critical to understand. While everyone focuses on the tremor and the movement problems, Parkinson's is so much more than that. The non-motor symptoms, things like sleep problems, constipation, even a loss of the sense of smell, can be just as debilitating, and they can sometimes show up years before any movement issues. So with such a broad range of symptoms, both motor and non-motor, you might be wondering, how on earth do doctors put all the pieces together to make a diagnosis? This is a key point. The diagnosis is almost entirely clinical. That means there isn't a simple blood test or a definitive brain scan that says, yes, this is Parkinson's. Instead, it really comes down to a skilled clinician taking a thorough history and performing a careful neurological exam to spot that classic pattern of symptoms we just talked about.
So, if it all relies on a clinical exam, how can we become more confident in the diagnosis, especially in the early days when symptoms might be very mild?
Well, it might surprise you, but one of our most powerful diagnostic tools is actually a trial of a medication. The thinking is pretty straightforward. If the core problem is a lack of dopamine, let's see what happens when we give some back. We use a drug called levodopa, which the brain turns into dopamine. And if a person has a big, sustained improvement on that medication, that is one of the strongest pieces of evidence we have for a diagnosis of Parkinson's disease.
And using levodopa as a diagnostic tool is the perfect bridge to our final section, how we manage Parkinson's disease in a long term. The goals here are multi-layered. First and foremost, we want to address the root of the motor problems by restoring dopamine function. From there, we work on managing the whole spectrum of symptoms. But the overarching goal, always, is to maximize a person's ability to stay active and maintain their quality of life. And for some, when medications aren't working as well, surgery can become an option. Our medication toolkit primarily targets that dopamine system. Levodopa is still the most effective drug we have because it's a direct replacement for what's missing. Then you have other classes. Dopamine agonists, for example, basically mimic or copy the effects of dopamine in the brain. Other drugs like MAOB and COMT inhibitors work by protecting the dopamine that's already there, preventing it from being broken down too quickly. Now, for certain patients, when medications stop providing that smooth, consistent control, there's an advanced therapy called deep brain stimulation, or DBS. It involves a surgical procedure to place tiny electrodes in specific parts of the brain. These electrodes then send small electrical signals to help regulate the faulty brain circuits. For the right person, the results can be absolutely life-changing. And that brings us to the future. As we learn more and more about the fundamental biology of this disease, what makes that synuclein protein misfold in the first place? We're opening doors to brand new types of therapies. The real hope is to one day move beyond just treating symptoms and find ways to actually slow or maybe even stop the disease in its tracks. I hope you enjoyed this video. Please feel free to share your experience or questions in the comments. Please note that I won't answer personal questions. If you found this video helpful, don't forget to subscribe to my channel.